Specialty Stories, session number 80. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week, where I have an amazing discussion with a physician, talking to them about their specialty, why they went into it, what they like about it, what they don't like about it, and maybe what you should be thinking about if you are interested in it. This week I'm talking to Dr. Mary McHugh, a urologist who's been out in practice for a year and a half, about her journey to urology, especially as a female in a very male-dominated specialty. We start off the discussion with how she initially became interested in urology.
When I was a second-year student during my classroom time, our school actually has a 6-week genitourinary block. And for the first 3 weeks of the course, they bring in urologists and they do all the lectures. And then the second half of that course is OBGYN. So I was exposed fairly early. They brought in a bunch of lecturers who were highly entertaining. They had great personalities and jokes, and they showed videos of the robot. And I was like, this is awesome. How do I become a urologist? And from that moment forward, I was sort of introduced to this concept of a specialty that I had never even considered, didn't really know much about, but it really sparked my interest in learning more about surgical fields.
Well, aren't women supposed to be OBGYN and men supposed to be urologists? What was it that was... First of all, you were like, I never thought about that. Was there a gender bias in your mind, or you just never thought about urology, period?
I just never thought about urology, period. And I think there were gender biases in my mind because I come from a family that has a lot of medical professionals. My dad's a doctor, and I had sort of always thought, I'm not sure who planted the seed, but I had always sort of thought like women didn't become surgeons. And it sounds really silly and naive looking back on that, but I just sort of always thought that I would do something that was not procedurally based or medicine based. And I didn't really, I don't know, I guess I didn't experience that bias when I took the course, and I'm trying to think back, and I don't think there really was a single female lecturer in the course, to be honest. I think every single person that came and talked to us was a man. So it's kind of interesting that I ended up down this path.
Yeah, we'll talk more about gender a little bit later, but what was it about, what do you think it was about what you were seeing outside of, ooh, look at that cool technology? That was like, I'm going to go play with penises and urethras and all of that fun stuff.
Yeah, so I think it was really a mix between medical management, procedures, and surgery. And I liked the organ system. I liked the anatomy. I liked that, some of the problems had to deal with quality of life. I wouldn't want to be in a specialty where 100% of the issues people deal with are quality of life, but certainly if you can make that sort of impact and make it fairly quick, I think it leads to a lot of satisfaction for the patient as well as the physician. And there's a lot of different disease processes in urology. On a given day, I'm sort of like managing metabolic issues that are leading to stone disease, and I get to be a cancer doctor and deal with a lot of different type of cancer. So it's a wide variety and a lot of different things in a given day.
For a student listening who may not have exposure to understand what you mean by quality of life and affecting quality of life, what do you mean by that? Can you give a specific example?
Yeah, so let's talk about one of the biggest quality of life issues is overactive bladder or urinary frequency, for example. This would not be considered to be a life-threatening illness in somebody who is not having, rip-roaring infections, or they're not having some anatomic problem, or they're not emptying their bladder all the way, and that's why they're having this issue and they're leaking. But it's something that certainly affects how they carry out their daily activities. And some people get so bothered by this. They can't, for instance, if they're a teacher, they can't go through a whole period without asking somebody to have to watch the class to pee, or they can't get sleep at night because they're up every 20, 30 minutes and going to the bathroom. So that's a quality of life issue, and there's a lot of things that we can do to help people fix that they never even realize until they step foot in a urologist's office. Another example is stress urinary incontinence. And this is leakage, anytime there's increased intra-abdominal pressure. So when a man or a woman coughs, laughs, or sneezes, they may leak urine. And again, not a life-threatening condition, but certainly can be ostracizing, can interfere with things that they like to do, running, dancing, horseback riding, hiking. And there's things that we can do as urologists also to help improve that. So those are just a few of the quality of life issues that we deal with on a daily basis.
What personal traits do you think lead to someone being a good urologist?
I think to be a good urologist, you have to be a good listener and a good communicator. A lot of people come into my office with very sensitive issues, dealing with a very sensitive area of the body. And I think they want to feel like they've been heard and understood. And certainly as a woman, you sort of get a lot of people, male patients especially, that are very shy when they come in. But you have to make them feel at ease and make them feel like they can open up to you and talk to you and really get to the root of the problem. And I think anybody who is going to be counseling patients on procedures, you really have to be a good communicator. You have to set expectations and be very clear about what's happening, what the potential risks and complications, side effects, etc. And so that patients really know what they're getting into when they're signing up for surgery. And I think that's not unique to what I do. It's probably anybody who's a proceduralist should have that skill.
Once your eyes were opened up to the surgical world and thinking about getting into the operating room and doing procedures, were there any other specialties in the running potentially that came into mind when you were like, oh, maybe I can do that?
So I was kind of all over the place. Before, I guess it kind of precedes my interest in urology, but before I sort of got interested in learning about surgery, I had thought the first thing I ever wanted to be in 8th grade was a dermatologist. And then somehow that switched to GI because I majored in nutrition in college. And then that somehow switched to peds. And then it just became urology after I took the course and went on my clerkships. And I had chosen a clerkship path where surgery was the second rotation so that I would be able to really make that decision right away that, did I want to be in an operating room or was this not for me? So I could decide fairly quickly that if my interest actually would come to fruition.
You mentioned a couple types of patients, a couple types of disease processes that you see. What are some of the most common things that you're seeing day in and day out?
Yeah, so I already mentioned overactive bladder, stress urinary incontinence. I deal with a lot of, voiding symptoms in men, whether they're due to enlarged prostate. There's erectile dysfunction that I see. A big one that I see on a daily basis is recurrent infections, especially as a woman. You're going to get those types of consults that male doctors don't necessarily see in their practice. I also see a lot of chronic bladder pain syndromes or interstitial cystitis, and I think that also lends itself to being a woman and somebody who's experienced in treating those problems. And I see stones very often, and I get sent a lot of hematuria workups, whether it be microscopic hematuria or gross hematuria. So those are probably, I've got one of those on my schedule every day in my office.
What percentage of patients that you're seeing are coming to you with a diagnosis and you're just doing a definitive treatment, or what percentage are you actually doing the workup and trying to figure out what's going on?
That's a really good question because of the area that I practice in. So I practice in northern New Jersey and I'm in private practice. And I would say 70% probably come to me de novo, where it's like the primaries are an OBGYN will identify a problem, and then they'll send the patient to me and say, this is what they're referred for. And then I sort of go from there and do everything on my own. I would say the other 30% are looking for another opinion, or they've had things done, or they've seen another urologist. We're probably, I can't remember the exact quote that another urologist gave me, but he basically said, you can't turn around and spit without hitting another urologist in the state of New Jersey. So I get a lot of that, and there's a lot of patients that have had, these extensive workups or a lot of testing by somebody else, and they sort of have failed to agree with either what, the doctor has diagnosed with them, or want to see if I have anything else to offer. So I would say about 70% come in, nothing done, and then maybe 30% come with some things done or a lot of things done.
Now, you mentioned that you're in a community or private practice setting. What was the decision matrix for you to decide to go out into the community versus staying in an academic setting?
Yeah, so that's another great question. So there's a lot of influences, I think, when you're especially in a two-physician marriage. So my husband came out of his training first, finished his fellowship, and wanted a specific job in a specific location. So he moved while I was finishing my last year of residency, and then I was sort of left to the devices of the job market. And I had always envisioned myself going into private practice. I think it's my personal opinion that it would be very difficult to sort of provide training and mentorship to residents when you haven't yourself been out in practice or out in the world. And I think that would be extremely difficult and daunting as a new graduate, and something that I didn't want to undertake. So that automatically, I don't think, really was a choice for me. I like the independence of private practice. I'm sort of always like doing things myself. Some of my favorite times in residency were being on call on the weekends and just being able to do things at my own pace, at my way. And sometimes that's nice to have. But it was the job market and I think my own style and personality that really influenced me to go into private practice.
Describe a typical day.
So it depends on the day of the week. Mondays for me are full days in the office seeing patients. Wednesdays are full days in the office seeing patients. Fridays are procedures that we do in the office. So I do cystoscopy in my office, which is looking inside the bladder. I do vasectomy, which is male sterilization. I do my own urodynamics in my office. And then whatever other procedures, sometimes it's small excisions of lesions, little things like that, whether it be penile or scrotal lesions. And then we have the capability of doing prostate biopsies with ultrasound in my office, which get done on Fridays. And then we do some other sister procedures like injections of Botox into the bladder. Tuesdays and Thursdays are a little bit more variable. As a new attending, especially in this area where we are very saturated with physicians, it's very hard to get block time. I've been out for a year and a half. I don't have a block. So when I put cases on my schedule, they get added to the hospitals that I'm on staff at whatever times they can do them. So for instance, this week I had a half a day in my office on Tuesday, and then the OR after that because they couldn't get my cases any earlier. And then today was the OR. So it's very variable, but it ends up being 3 days in my office, 3 full days, and then, whatever surgeries we have to schedule on Tuesdays and Thursdays. And then even Saturday surgery is a possibility for me. And it just really depends on my schedule and the patient's schedule. So it's a lot.
Now, when you said because you're a new attending and you're not able to get block time, for somebody who may not know, you're talking about at the hospital for them to dedicate an operating room for you during certain days, certain times. You just get the leftovers.
Yeah, so it can be really variable. If someone doesn't utilize their scheduled time that they have, then I could have a 7:30 start and take over their block. Or it could be like we can't fit you in until everybody else is sort of done for the day. So it's really variable. And the ways that, just for anybody that is interested, the way you get block time is either the easiest way when you're a new physician is to acquire somebody else's block, or to be employed by the hospital system who's running the OR, because you'll be more likely to get that scheduled time. And I didn't think that I was going to like that at first. I really like knowing where I'm going to be and, just a regimented schedule, but it actually has worked out quite nicely.
Now, what percentage of patients are you that you're seeing are you actually taking to the OR doing procedures on in the office?
Yeah, so for me, I think that it's a pretty low percentage. A lot of the consultations that I get sent are a lot of non-operative patients. I would probably say about 20 to 25% of all of the patients that I see probably ultimately end up having a procedure, whether it be in the office or having surgery. And I think that I don't know if there's any data about that, or if anybody has ever studied those patterns, but I tend to think that mine's a little bit lower, and I think that is a construct of my gender, to be 100% honest.
Is that disappointing? Obviously, as somebody who likes the operating room and wants to do procedures, you want to be there all the time.
Absolutely. And I think it is a little disappointing. And, I've had this discussion with other women. And I think I'm fairly early in my career. And I think, you sort of gain the trust of your referrals, or your name gets out there the more you do operate. And I think that, you do the cases that you can, and you do the best that you can, and you have the best outcomes that you can, and that's how you build your reputation. And I think that, again, being in an area that's really saturated and there's a lot of people here, it takes time. And I think that's one of the biggest things that we all need to realize coming out, is that it takes time to build, and it takes time to establish yourself and establish your reputation. And don't believe that, everything you see on Instagram where everyone has 10,000 cases their first day. Although, if you were to interview my husband, it would be a different story. But no, I think it does take time. And I think as a woman, you sort of, you learn that even though the consults may be non-op, those patients, they really need you too. So you find a way to make it a part of your practice and enjoy it.
Let's talk a little bit more about gender, since you brought it up again. Why is urology such a male-dominated specialty?
I think it really just has to do with the fact that, the male urinary system and the male genitals, that I think a lot of men traditionally were the ones who went into the specialty. And I think it's the perception of a lot of patients that only males will treat that part of the body or look at that part of the body. So I think it has to do with, traditionally who was in the specialty. And I think in medicine in general, when you look back, 20, 30, 40 years, we, look at the way that the gender breakdown was, and just inherently, I think every specialty was probably more male dominated. And then, well,
it's bad for women to work. Isn't that what we thought before?
That's what we thought. We stay at home and, eat bonbons, and it's great. No, but I think, when you look at the breakdowns, and the American Urologic Association releases all the data about the match, and women are definitely gaining steam for sure. We're still a little bit more of a rarity in the field, but there's a lot more women being trained now, which I think is great for, male and female patients.
What does the call schedule look like as a community practitioner?
Yeah, so typically I'm in a very large urology group, but in my care center, there's only 2 of us. So your call for the practice is going to be split by whoever's in your care center, and that's typically how everyone else does it in our company as well. So it's basically every other night for me. And then ER call is determined by the hospitals. So one of the hospitals that I'm at assigns ER call a month at a time. So that gets, rolled into our practice call. So it's not too bad. And then just because of politics, some of the other hospitals keep the stronghold on the call and don't want outsiders taking it. So that's kind of a blessing in disguise for sure. For
call, are there urologic emergencies where it's like you're in the middle of dinner and like, oh, I got to go to the operating room now?
Yeah, so there's a few. Some of the emergencies that we see are necrotizing fasciitis of the genitals, which is Fournier's gangrene. That's an emergency that's got to go to the operating room right away. Testicular torsion is another one. You want to try to get those kids to the operating room as soon as possible and detours the testicle. Any abscesses, the most common ones we get consulted for are scrotal abscesses. You want to take care of that right away and make sure it's not something more than just an abscess. And then septic stones, those usually have to be taken to the OR right away, or at least be provided with some decompression of the urinary tract. And retention. Retention is a common one that we get consulted for all the time. And oftentimes they call you and patients are super uncomfortable and, you have to go take care of it. So those are just some. I know I'm probably missing a few. Yeah. But that's the short list.
I'll never forget being an intern, having a patient who had retention and we just could not get a Foley in him. And we had to call the urology resident, and he's like, "Are you kidding me?" And this guy just had so much urine, like his bladder, you could see through his stomach, like it was crazy.
Yeah, they can be quite large and quite painful. So, as long as you tried first, though.
Yes, we tried.
Gave you an A for effort.
Do you feel, especially as a female, do you feel like you have enough time for family when you're on call every other night as a urologist?
Yeah, so I don't have any children yet, but it's just me and my husband, and his hours are pretty long as well. So we have that time when we get home at night. It's a couple hours, and then the weekends. So whatever weekends he's not working, we will be with each other then. And it's a lot better than trading, I will say. And you kind of learn the sort of things that you can do to minimize your calls, or, you make sure everybody's questions are answered, or that everyone's tucked in. If you're doing a procedure on a Friday, that, everything's taken care of and you don't have to have any worries about that, when you go on call over the weekend. And it's a matter of sort of letting people know that you are available, but also telling them or explaining what kinds of things they should be calling you for. So all in all, I think our patients are really awesome. And when we're on call for the practice, it's not bad. It's just, when you have to admit somebody or somebody ends up in the ER, it's a patient known to you, septic with a stone, then it can derail you, but you take care of it.
What does the training path look like to become a urologist?
Yeah, so urology is its own training program. So in general, most urology programs are 5 years. Some are still 6 years. A lot of them have gone down to 5 years. The first year is a general surgical internship, and then it's usually 4 or 5 full years of urology. A lot of the programs, I think, that are 6 years do have built-in research year. So just keep that in mind, if you are applying, know how long the program is going to be. But it's all one program. You match into the whole thing through the urology match. So it's a match that precedes all the other matches. I think it maybe is after I think the military's first, but then the urology matches in December.
So urology is not through the NRMP?
No, it's through the American Urologic Association. They give you like a number, and you do it through them. It's its own unique match.
Do you know why they keep it separate?
I don't know, actually. I mean, I guess I think it's to be honest, a self-regulation issue.
Yeah.
When it's your specialty, you don't want to have so many people.
Hmm.
But that would be my guess. I can't really confirm that,
Yeah.
but I've heard of that in other specialties as well.
Yeah. Interesting. What's the competitiveness look like for matching into urology?
It's pretty competitive. I think that there are really specific statistics. If you go on, just Google the urology match, or go to, actually, there's a website, urologymatch.com. You can probably find a more specific breakdown. But I think there's not a lot of applicants, but I think it's like a 60% match rate for those applicants, but they kind of like break it down. And in general, you have to be pretty high performing as a student, and have good step scores. So it's definitely not very easy. And I think that the process is a little bit different now. I am a DO, and a lot of the programs that were traditionally, quote, DO are now in the urology match, accredited by the ACGME, so the single, graduate medical education system.
Mm-hmm.
So I think it's probably gotten a lot harder than when I matched, because it was a separate match. I applied into the urology match as well, just to apply to as many programs as possible. But they've done away with the programs that are like just AOA accredited. They're mostly all ACGME accredited at this point.
Yeah. Do you see any negative bias towards DOs in the field?
I think, having been on both sides of, the interview trail and as an interviewer, I think there is a lot of biases. And I think, your website breaks down per specialty, MD versus DO. And I think the data speaks for itself. And again, this is another thing about the Instagram world, where people are like, no, being a DO, you're equal, and you'll imagine a neurosurgery at Stanford, no problem. And, I've seen people walk through the door they're great applicants, they're DOs, and I've literally seen a 280 score on the USMLE. And these kids can't match anywhere.
Yeah.
And that's just reality. I'm not saying it's right. I'm not saying, that you can't reach for your dreams and really go for something that's super competitive, but the numbers speak for themselves. And I think that if you're listening to this and you want to have your pick of the specialties, and if you're a top performer in school and on standardized testing, then getting the MD degree is really going to open up all of the doors. It's not to say it can't be done as a DO. I know some DOs who have matched at really elite places have done very well, but that's more of the exception than the rule.
What opportunities are there to subspecialize as a urologist?
Yeah, so there's quite a few subspecialties within urology, and I'm sure I'm going to miss one of them. But so there's oncology. So there's 2-year and 1-year fellowships. The 2-year ones are generally accredited by the Society of Urologic Oncology. There's female pelvic medicine and reconstruction. There's 2-year and 1-year fellowships as well. The 2-year ones, you can actually sit for another board certification. The 1-year ones are not typically accredited by, I believe the governing board is, I think it's SUFU, Society of Urodynamics and Female Urology. Pediatrics is its own subspecialty. That's generally 2 years. There's reconstruction and trauma, which is typically 1 year long. There's andrology and male sexual health. I think that's usually a year. And then there's fertility, which I think, I'm not sure how long fertility is. I think it's a year. And those are the general subspecialties. I guess neurourology is also its own subspecialty. I'm not really actually familiar with any dedicated fellowships. I think that sometimes gets rolled into some of the other fellowships, but that's another area of subspecialization.
What do you wish primary care physicians knew about what you're doing day in and day out to help their patients and your patients in the future?
I think one of the things is that, there's a lot more technology and a lot more procedures to help patients now. And I commend, the primary care doctors for starting people on medication and working up a lot of the urinary complaints, and just to let them know that there's a lot of different things, like, for instance, Botox. Botox is for, patients that have frequency and urgency, and it's indicated if you've failed, typically 2 or more medications. And I think sometimes patients think that there's no solution, or they're sort of stuck with the medications, and they don't know that there's anything else available. And I think people are always so surprised when they learn about their options. So just maybe getting them into the urologist sooner, and not being afraid to just send over a patient to see if there's anything else we have to offer.
What other specialties do you work the closest with?
I would say general surgeons, OBGYNs, and then, it's mostly family practice and a lot of other, like, mid-level providers, PAs, NPs. Don't get a lot of referrals from other types of physicians.
Are there any opportunities outside of clinical medicine for urologists?
Some of them, I think, include, speaking engagements, although, like, New Jersey is a weird state for that. There's laws that sort of cap what your income is for doing work like that. There's always the expert witness stuff. I think that's a lot of urologists do that around here. And then, like, all the normal stuff, write books or consult.
What sorts of trials are urologists being expert witness? Is that, like, just malpractice kind of stuff?
Yeah, it's all malpractice stuff. I haven't really dug into it very much, but I think the American Urologic Association actually has an expert witness registry. You have to meet some requirements to be on it. You have to be out for a certain number of years, and you have to be board certified. But there's, like, a way to register, and then, you read all these things online, like, people put their profiles up on LinkedIn, and attorneys contact them for their stuff. So, yeah, not something that I've gotten involved with as of yet. Not sure I will. I don't know.
Okay. What do you know now that you wish you knew before going into urology?
I think a couple things. So I think that maybe one of the hardest parts of being a surgeon or your job is that you become extremely disappointed when something doesn't go according to plan, or someone has, like, a complication. And I think dealing with that the most is probably one of the hardest parts of my job, because it's emotionally taxing. So you sort of have to learn how to deal and cope with that. And then I think, we had sort of talked before about when you get out, everyone's so, like, bright-eyed and bushy-tailed and just ready to, like, soar and see all these patients and do all these procedures and stuff. And it takes time. And it takes time to develop a rhythm, and it takes time to develop finesse. And what you've done 10,000 times as a chief resident that you could do with your eyes closed suddenly becomes the hardest thing when you're an attending, and nobody's there, and the safety blanket's gone, and it's real. And I've had these discussions with other people, and it takes time. So I guess patience for the process, respect the process.
What do you like the most about being a urologist?
I like my patients. They're awesome. They're really great. I practice in a great area. They are just, like, the best. And they add to my job satisfaction 100%. I come from a pretty urban area in my training, and it's like different there. And now I'm sort of, like, out in the community, in the suburbs, and my patients come, they show up, they're like, they listen, they take their medication. It's awesome. And I love it. And I think they're the best. And they make my job, they make it very enjoyable.
What do you like the least?
I think it's probably,
besides charting. Everybody's answer is charting.
I know. That's true. I have a lot of notes to finish after this. I think it's, it's just sometimes you feel a little bit helpless in your ability to help people because you're constrained by what insurances will cover, or you give them a sample of medication and they're just elated and they're fixed. And then, they have Medicare and Medicare won't pay for any of their meds. And, that's an issue because people are on a fixed income and they can't afford these things. And I think that's really frustrating because you're always trying to call the companies or get these auths through or order imaging that is clearly indicated for, some oncologic process. And the reviewer on the other side of the phone, who you have no idea who they are, what their credentials are, if they even know what you're talking about, and they just say that the patient can't get their scans. And then you just have to go through appeals or, do all that stuff. And I think that's not unique to urology by any means. But I think it's another annoying part of the job is you just want to do the right thing and help your patients. And sometimes, the insurances make that impossible.
If you had to do it all over again, would you still be a urologist?
That's a pretty loaded question. I think I would. I think, you sort of think, could I have done this or should I have done that? And I think, again, on social media, you see these people with, everyone's so happy after their abdominoplasty or their Botox that they get in their face. And it's like, I think when it comes down to it, you have to think about what complaints or complications you want to deal with. Do you want to deal with the person who gets the Botox and now is obsessed with the 1 millimeter difference in their eyebrows? Mm-hmm. Or do you want to deal with the person who's having a little bit of discomfort after you've operated on them for a kidney stone from their stent, but they know their stent's going to come out in a week? And I think it's just, you go into medicine and you kind of get stuck, right? You got a lot of loans to pay unless you're independently wealthy. And so do I wish I picked a different specialty? I don't think so. I don't think the grass is really ever always greener for other people or people that are accepting cash only in their practices. And my husband and I have that discussion all of the time. But we both agree that we're probably in the right place.
Any last words of wisdom for the med student listening to this or the pre-med student listening to this who may have their eyes open to urology now?
Yeah, so I think, stay interested, read as much as you can when you can. Getting exposure early is key. If you are a medical student, it's all the normal things that you should do to match into a competitive specialty. So learn, the people who are on the faculty at your institution, get involved with research, meet the residents, get that chairman's letter if you do have a department, so it looks good for your applications. Just try to study as much as you can for everything, do as well as you can on your steps, and you'll succeed.
All right, there you have it. Again, Dr. Mary McHugh, a urologist for a year and a half out of training, about what drove her to urology, what she likes about urology, and so much more. I hope you are enjoying these episodes. We have some more great episodes coming up for you. I know we had a little hiatus with episodes, but now we are back on track and have some more great episodes for you here to come. So don't forget to subscribe. Don't forget to tell your classmates all about specialty stories and how they can subscribe to the podcast and learn about different specialists as well. Hope you have a great week. We'll see you next time as we talk to Dr. Nicholas Volpe, a chairman of ophthalmology.